Today we're going to look at deep vein thrombosis. Okay, my name is Dr. Stanom Kandawe, a current practitioner at Levi Mwanawasa Teaching Hospital. Deep vein thrombosis and pulmonary embolism collectively make up a condition known as venous thromboembolism. Okay, so to appreciate this topic, we need to look at the anatomy of the vein and the artery. The vein is made up of a valve, a tunica intima, a connective tissue, a tunica media, and a tunica adventitia. All these structures are important because they're going to help us furthermore interrogate what we're talking about. Okay, so now for us to further understand this, we need to know that in the blood vessels, such as the vein, receive blood moving in a lower pressure, or blood moves at a lower pressure in the vein. Okay, in the artery, blood moves at a higher pressure. That's why the veins have got the valves which prevent the backflow of blood, so that there is blood keeps on propagating in one direction. Okay. Now, with deep vein thrombosis, as we move on, we'll further discuss how deep vein thrombosis can destroy the patency of the vein. Okay, because it destroys the valves when deep vein thrombosis starts happening. If it can destroy the patency of the valves, we'll look at that under the pathophysiology of deep vein thrombosis. Now, what is a deep vein thrombosis? Yes, deep vein thrombosis is simply a formation of a blood clot in one of the deep veins of the body, usually in the leg. Okay, a thrombus is a clot that forms inside the blood vessel or the heart. A thrombus that dislodges and travels to one part of the body is known as an embolus. Okay, it's a mobile. In short, when we say a mobile thrombus is an emboli, it's easy for you to remember. Okay, now let's look at an interesting mechanism which we call the coagulation cascade or coagulation pathway. This is a pathway which comprises of three pathways, to be specific: the intrinsic pathway, the extrinsic pathway, and the common pathway. For example, when you injure yourself in the kitchen and you cut yourself, the pathway which is activated is what we call the extrinsic pathway. When you're traveling in a bus for a long time, you're immobile, and the red blood cells come into constant contact with your blood vessel, the pathway which is activated is what we call the intrinsic pathway. Now, after understanding this concept, we need to understand or know the coagulation cascade, because this is where the drugs which we're going to talk about are going to be acting. The drugs of the anticoagulants which we use in deep vein thrombosis simply act on the what? On the factors of the coagulation cascade. So the intrinsic pathway starts with factor 12, factor 11, factor 9, and factor 8. Okay, and eventually it goes into the common pathway, which is factor 10, and factor 10 is converted to factor 10A, and factor 10A converts the prothrombin into thrombin, and from there the thrombin is further converted into fibrinogen, which is fibrinogen is further converted into a stable clot, which is a fibrin. Okay, so now that's the pathway of the intrinsic the pathway of the intrinsic process. Now, for the extrinsic pathway, it starts with factor 7 and goes into the common pathway. Okay, so when it comes from factor 7 goes to the common pathway, the same process occurs. Okay, of each forming a stable clot. Okay, so now when this happens, we need to understand that the drugs that we're going to use, the anticoagulants such as warfarin and heparin. Okay, warfarin acts on vitamin K dependent factors such as what? Factor 9, factor 7, factor 2, and factor 10 itself. Okay, so the warfarin is going to act on those factors to prevent the formation of a clot. Okay, the heparin is going to act on antithrombin 3 to prevent the formation of a clot. Okay, with this understanding of this concept, it's easy for us to know that these drugs work in such a manner, and it's going to be easy for us to treat our patients in our setting. Okay, so with that understanding, we need to further discuss the anticoagulants. Okay, heparin, the mechanism of action, it inhibits vitamin K reductase. Okay, while heparin inhibits antithrombin 3. Okay, the factors involved for warfarin are the vitamin K and dependent factors such as factor 2, factor 7, factor 9, factor 10. Okay. And for heparin, the factors which are involved are factor 2A and factor 10A. Okay, the pathway which warfarin acts on is the extrinsic pathway and the common pathway. Okay, and the pathway which warfarin or heparin works on is the intrinsic pathway and the common pathway. Okay, with this understanding, it's very easy for us to know how to treat this condition. Okay, so now when you're giving these anticoagulants, you need to put the patients on observation or what we call monitoring. Okay, for patients who are on warfarin, we need to check the international normalized ratio, which is the INR, which is usually between 2 to 3 on patients on anticoagulants. When it's below 2, the blood becomes too thick. We need to prevent that. And when it's greater than 3, the blood becomes too thin, so it can predispose the patient to bleeding. Okay, so what do we do for these patients? We need to make sure that the INR is between 2 to 3. But someone may ask you to say, what is the normal INR for someone who is not on anticoagulation therapy, who is not on warfarin or heparin or any sort of anticoagulant? The normal answer you should give is 1, but there's a ratio which is 0.8 to 1.2. Okay, so the normal INR for someone who's not on any anticoagulant is 0.8 to 1.2. Okay, now the other parameter you should monitor is the prothrombin time in the patient on warfarin, and the other parameter you should measure when the patient is on heparin is the activated partial thromboplastin time. Okay, so the route of administration for heparin is intravenous, and the route of administration for warfarin is taken orally. Okay, so warfarin is very slow. It has a slow onset, but it has got a longer duration. Okay, and heparin is it has got a rapid onset and a short duration. I like to just say warfarin is it's a tortoise, and heparin is more faster. It's like a cheetah or a rabbit. Okay, one of my consultants used to say that. Okay, so warfarin crosses the placenta, and heparin does not cross the placenta. Now, for patients on these types of drugs, you need to know the antidotes. So for the antidote for warfarin is vitamin K, and the antidote for heparin is protamine. Okay, we need to know this because in case these patients react to these drugs or they have a bleeding tendency, we need to be able to reverse that bleeding tendency which can occur in these patients. Okay, so we've talked about the coagulation cascade, and we're going to further look at a great scientist who discovered what we call a Virchow's triad. More than 100 years ago, Rudolf Virchow described a triad of factors. Okay, the triad of factors consists of 3 factors that contribute to a formation of a clot or a thrombi. These factors are called the venous stasis, endothelial damage, and a hypercoagulable state. Okay, so we're going to look at these factors in further detail. So stasis just simply means there's reduced blood flow. Okay. Then endothelial injury just means there's injury to the vessel or the blood vessel. Okay. The hypercoagulable state is what means the blood can easily be predisposed to developing a clot. Okay, due to external factors which we're going to talk about. Now, for stasis, okay, what things can cause a patient to have reduced blood flow, okay, in a particular vein? Okay, that's when you say a patient who has been bedridden for greater than 1 week or 5 days can be predisposed to having a clot in their system, in their blood. Okay, patients who have a long-standing history of traveling. Okay, it can be an aeroplane, it can be on a bus, long travel because they're not moving. Okay, we have got hypercoagulable state. So hypercoagulable state, it can be classified into 2 factors. Okay, it can be acquired and hereditary. Okay, under acquired factors, we've got cancers, we've got chemotherapy, we've got oral contraceptive pills, we've got hormonal replacement therapy, we've got pregnancy, we've got obesity. Okay, So these factors, these acquired factors, increase the procoagulants in the body, okay, and decrease the anticoagulants in your body. When you have more coagulants in your body, you have got a higher risk of developing what? A clot, okay, because when you have higher procoagulants, you surpass the what we call the anticoagulants. Okay, then we've got hereditary factors like factor 5 Leiden. Okay, protein C and S deficiency, which is commonly found in nephrotic syndrome. So those patients can be predisposed to bleeding tendencies. Okay, we also have patients who have got systemic lupus. Erythromatous disease, those patients have got a high chance of developing a clot. Okay. The other thing we need to talk about is endothelial damage or vessel injury. Okay, endothelial damage can be caused by smoking, can be caused by hypertension. Okay, okay, so that's endothelial dysfunction, and endothelial damage can also be further be caused by surgery, catheters, okay, central venous catheters, trauma, um, dialysis catheters. All those things can cause contribute to the formation of a clot. Okay, now we're going to further talk about what we want to know today is because of venous stasis. What further things can contribute to someone having venous stasis, okay, or reduced blood flow in a vein? We've talked about prolonged bed rest more than 1 week or 4 days, okay, a cast on the leg, limb paralysis from stroke, spinal cord injury, extended travel in a vehicle, age greater than 65. All these factors can contribute. We've got hypercoagulable state. Okay, we've got what things can cause hypocoagulable state. We've talked about the hereditary and the acquired factors. Okay, the acquired factors, things like surgery, can trauma. Okay, we've got malignancy. We've got increased estrogen through the hormone replacement therapy. All these things can cause a patient to have a thrombus in their vein. We also have inherited conditions which are called hereditary factors such as protein S deficiency and the antithrombin 3. So conditions which predispose to patients to bleeding, thrombophilias can cause the patient to develop a clot. We also have acquired coagulation disorders such as antiphospholipid disorders, nephrotic syndrome, systemic lupus erythromatous disease, SLE. Okay, all these things can cause the patient to have what? To have a thrombus. We also have endothelial injury. Okay, so endothelial injury can be caused by trauma, surgery, placing wires, dialysis access catheters, repetitive motion injury, central venous catheters, which can be subclavian, internal jugular lines. Okay, all these things can cause a patient to have what we call a clot in their blood system. Okay, so the other thing that we can talk about is the pathophysiology. Okay, according to the three factors we've talked about, all those three factors can contribute to a patient developing a clot. When that happens, when there's endothelial damage, there's venous stasis and hypocoagulable state, the platelets aggregate at a particular site. When the platelets aggregate at a particular site, they form a fibrin meshwork, okay, which is the initial clot. When that happens, the right blood cells, instead of just passing through the vein, they begin to get trapped into the what we call the that fibrin meshwork. Okay, when that happens, when there's that blockage in the vein, the thrombus propagates in the direction of the blood flow because it's been trapped. It will continue gathering more and more, and the thrombus will keep on getting bigger, and that thrombus now will flow in the direction of the blood flow. So now what happens to this system? Your body has got a response. Okay, what's the first response in which the body reacts? It will have inflammation. Inflammation will be triggered. There will be tenderness. There will be swelling. There will be erythema. Okay, now pieces of that thrombus will begin to break loose and travel through the circulation, which we call an emboli. Okay, that's why this condition is very dangerous if it's not treated in a very good way or promptly. Okay, so what happens when that emboli is formed? The body has got a way in which it's going to react to that thrombi. It's going to try to form what we call, it's going to send the fibroblasts, which are eventually going to invade the thrombus, and eventually while they're invading the thrombus, they're going to injure the patency of the valves. Okay, so the patterns of the valve will be permanently damaged, and without that patterns of the valves, blood will begin to flow back instead of propagating in one direction. Okay, so that's the effect of all these three factors we've talked about. Okay, that clot is going to form a fibrin meshwork, which is going to keep on trapping the red blood cells and form a bigger clot. Okay, that clot, which now becomes a thrombus, is going to start breaking loose and going to start propagating in different parts of the body, and it's going to cause different symptomatology. And the most common one, which if we ignore it for a long time, it's going to cause pulmonary embolism, which can eventually lead to death. Okay, so the other presentations of these patients, they can present with inflammation, which we call thrombophlebitis. Okay, so thrombus accompanied by inflammation of the vein. Okay, then we've got thrombosis, which refers to thrombus with minimal inflammation. Okay, so there's just dislodgement and migration of the thrombus. So inflammation with a thrombus is what we're going to call thrombophlebitis. Okay, so now that dislodgement and migration of a thrombus is known as thromboembolism. Okay, so which is common in what we call thrombosis. Okay, so now what I would like to just clear out here is that the what I would like to clear out is that DVT it occurs unilaterally. It occurs in one leg. Okay, if it occurs in two legs, you need to further look for another cause, because it's rare that that happens, and you need to probe more to find if it can be something else which is accompanying the DVT as well. Okay, so common clinical manifestations which are unilateral, they can be calf pain or tenderness, there'll be swelling, the spitting edema, there will be increased temperature and fever. How do you check for that increased temperature? You need to check the temperature for both legs and compare. Okay, you need to check for superficial venous dilatation. You need to check for cyanosis, which can occur with severe obstruction. Okay, because there's no enough oxygen propagating into one direction. You find that there's increased accumulation of carbon dioxide, so the patient's leg will appear cyanotic. Okay, so we need to check for all those things. Okay, some of the complications of venous thromboembolism, of a deep vein thrombosis, are what we call pulmonary embolism. We've got phlegmasia albadolens, we've got phlegmasia cellular dolens, and venous gangrene. Okay, these are just a clinical spectrum of the same disorder. Okay, now phlegmasia albadolens is just simply a thrombosis in one of the major deep veins channels. Okay, so this thrombosis, it happens in one vein, but it does not go spread to other veins. So it's just it spares the collateral veins. Okay, it causes congestion and edema and lymphangitis, and it further causes edema. Okay, so it's just congestion in one particular vein. Okay, then we have got phlegmasia cellular dolens, which which spreads to the collateral vessels and causes massive fluid sequestration and edema and congestions. Okay, so you can imagine there's now an effect of the uh, oncotic pressure there, and uh, all those things happening there, because it's now spreading to the collateral vessels. Okay, so now, clinically, how do you examine someone who comes in with, after doing your history, using the virtual stride, all those risk factors you talk about them, you now have to do a clinical examination, which involves you palpating the distal pulses, evaluating the capillary refill time, okay, and to assess the limb perfusion, to palpate all the joints, to rule out acute arthritis. You also need to do a neurological evaluation, which may detect nerve root irritation, okay, and also examine for reflex defects, okay, the sensory and the motor defects, okay. So the other thing you're going to do for these patients is the examination is called the Homan sign, where you're going to dorsiflex the foot, okay, or you're going to do dorsiflex the foot, and when you dorsiflex the foot, you're going to feel pain, or the patient is going to feel pain in the posterior calf. We need to be very careful when doing this examination, because they can cause or lead the clot to propagate further, okay. So we need to be very careful when doing such an examination. We also have a Moses sign, which is just gentle squeezing, or it's called the Moses sign or a Bancroft sign, okay, or which is just gentle squeezing of the lower part of the calf from side to side, okay. We also have a Linton sign or a Trendelenburg test. Okay, you apply a tourniquet at the saphenofemoral juncture there and ask the patient to walk. Okay, then the limp, you check, you observe the patient if they are going to be elevated superficial veins, which you're going to observe there. Okay, elevation in the superficial veins, which you're going to observe there. Okay, so that's the Moses sign, okay, also known as the Bancroft sign, okay. So the other thing you're going to do after you have done your clinical examination and your history, what you need to do now is diagnostic evaluation, okay. Diagnostic evaluation, you're going to do your lab studies. You're going to do a clotting time, uh, activated partial thromboplastin time, the bleeding time, the hemoglobin. Okay, you're going to check your hemoglobin to assess if this patient is anemic. Okay, you're going to check your international normalized ratio. Okay, and your answer should give you clues to what you're going to do to this patient. Okay, if it's greater than 2, if it's less than 2, or greater than 3, you're going to know what you're supposed to do. Or it's this patient has never been on anticoagulation therapy, so now you need to treat him as a first time occurrence. Okay, you're going to check the platelet count. You want to rule out the thrombocytopenias or any hereditary disorders. Okay, you need to check for this patient. You're going to check for the D-dimer. You're going to do a D-dimer test, and you're also going to do some imaging investigations, which are very important, like a venous Doppler ultrasound, because you're going to be using sound waves to detect where the clot is. Okay, you're going to do a venography, a CT scan. Okay, all these investigations are very important. Even an MRI scan can be done. Okay, so the imaging studies can be classified into a venograph. A venograph, which is the gold standard investigation for different thrombosis. It involves you getting a contrast dye and inserting it into the particular vein, okay, in the iliofemoral juncture there, and it will flow, and you have to capture on X-ray to see where the clot is, where the occlusion is, where there's occlusion of the of blood there, okay, where the clot is. Okay, the non-invasive ones, you can use ultrasound, you can use a plethysmography, you can do MRI techniques. Okay, so this is just an example of what happens when you do a venography. You capture it on X-ray there, it will show you where the clot is. Okay, we can also do nuclear studies where we're going to use a radioisotope which incorporates a growing thrombus. We're going to detect if it's a new clot or an old clot. Okay, so you're also going to do a plethysmography, which is just measures the change in the extremity of volume in response to the stimuli. Okay, you're also going to now, after you've done your investigations, you're going to do we have a scoring system, which is the Wells scoring system for DVT. So according to the points, someone might be asking yourself, why is it important to do this system? Because according to the points of these patients get, we're going to know which route we're going to take. Okay, it's very important to do a Wells score, because it will direct you or give you an algorithmic approach on what to do next. So for active cancer, it's a score of 1. Okay, for paralysis, okay, or paresthesia is a score of 1. Immobilization of the lower limb is a score of 1. If the patient has been bedridden for greater than 3 days because of surgery within the past 12 weeks, is a score of 1. Localized tenderness along the distribution of the deep veins is a score of 1. The entire leg swelling is a score of 1. Unilateral calf swelling greater than 3 centimeters is a score of 1. Unilateral pittal edema is a pitting edema is a score of 1. Collateral superficial veins is a score of 1. Alternative diagnosis likely or more likely than DVT. If you are querying other diagnoses, it's a score of -2. Okay, if this patient has got a prior history of DVT or pulmonary embolism, it's a score of 1. So now, after you've assessed your patient and you find that this patient has got a score of 3 or higher, there's a high risk of them having a DVT. If it's 1 or 2, it's a moderate risk, and if a score of 0 is less, it's a lesser risk. Now, this is going to give you an algorithmic diagnostic approach for the imaging that you're going to do. After you assess your clinical code, now you're going to check if this patient has a score has a low score. You're going to take them for a D dimer. Okay, if the D dimer is normal, they have no DVT. You rule it out. If the D-dimer they have a low risk, but the D-dimer is high, you further go for an imaging test. Okay. If the score is high, don't even waste time. Just go direct to an imaging test, which is you can do a Doppler ultrasound for them. Okay. Now, for these patients, we need to have more differential diagnosis for these patients. And when they ask you for differentials, you need to be very precise and tell them that there are a number of them. So you can have cellulitis, you can have thrombophlebitis, you can have arthritis, you can have a symmetrical peripheral edema secondary to congestive heart failure, liver disease, renal failure, or nephrotic syndrome because of those protein C and S deficiencies. Okay, lymphangitis. There can be extrinsic compression of an iliac vein secondary to a tumor. Okay, a hematoma or an abscess. Okay, we can have lymph edema. We can have a ruptured Becker cyst. We can have stress fractures. We can have bony lesions. We can have superficial thrombophlebitis. We can have varicose veins. Okay. So now that we've known how to diagnose DVT, okay, we've known what can cause the risk factors, we've known the clinical examination to do, we've known the history, okay, we've known how to calculate the wall score. We need to know what specific treatment we're going to do for our patients. Okay, so the mainstay treatment for this patient is what we call anticoagulation. Okay, in which we talked about we're going to use warfarin and heparin. Okay, or any type of anticoagulants for these patients. We also have a thrombotic therapy for DVT. We can use thrombolytics like actelapase. Okay, we have got surgery for DVT. We can do a thrombectomy. Okay, we can do that thrombectomy can be accompanied by venous cover filters. Okay, we can also do compression stockings. Okay, now the management for DVT, the mainstay management for managing a DVT is like you don't want this patient to, you don't want to risk them to having a pulmonary embolism, which is very deadly and severe. Okay, you want to reduce the morbidity as well. You want to prevent the risk of developing a post thrombotic syndrome. Okay, so the mainstay is anticoagulation. So we're going to look at the types of anticoagulants to use. Okay, we've got vitamin K antagonists like warfarin. We've got the indirect thrombin inhibitors. We've got the direct thrombin inhibitors. We've got factor 10 inhibitors. Okay, so the main goal of this, the other class which we can talk about is the direct oral anticoagulants. Okay, such as the Pixaban, rivaroxaban. Okay, those are the direct oral anticoagulants. Now, the advantages of direct oral anticoagulants is that they do not need monitoring. Most of these drugs that we've mentioned, these classes, they need monitoring. You need to be checking the INR constantly and the prothrombin time. But for the direct the direct oral anticoagulants, you don't need to you don't need to monitor the patient more often. That's the new standard of treatment which has been used in most countries. Okay, the mainstay action for these anticoagulants is it does not dissolve the clot, but there's lysis of lysis of the clot begins spontaneously through the body's intrinsic fibrinolytic system. Okay, so the clotting cascade is what's going to cause lysis of the of the clot, because these things just go away there on the clotting cascade. Now you need to know when not to give anticoagulants. When there's intracranial bleeding, we don't give anticoagulants. When there's severe active bleeding, we don't give anticoagulants. When there's recent or brain or spinal cord or eye injury, we don't give anticoagulants. When in pregnancy, we don't give we don't anticoagulate. When there's malignant hypertension, we don't anticoagulate. We have got relative contraindications such as a recent major surgery, recent CVA, severe thrombocytopenia. Okay. So as we've mentioned earlier on, the drugs that we're going to use here are vitamin K antagonists, which have got the warfarin, we've got the unfractionated heparin, we've got the, excuse me, we've got the low molecular heparin, okay, low molecular weight heparin, the enoxipam, the enoxaparin, which is just simply Clexane. The brand name is Clexane. We got tinaparin, sorry about that, tinaparin, dotaparin, all these drugs. Okay, so there are shorter heparin chains which have increased affinity for inhibiting factor 10A. Okay, we've got direct thrombin inhibitors. Okay, and we also have factor 10A inhibitors like Fandaparinex, okay, which directly or indirectly produces rapid anticoagulation. Okay, so it's very important to know these groups of drugs because you need to have a multi-diverse approach when treating patients with deep vein thrombosis. Okay, the other type of drug we need to know is the direct oral anticoagulants. Direct oral anticoagulants are rivaroxaban. Okay, the dosage is just 15 milligrams BD for 21 days, followed by 20 milligrams once a day. Okay, we also have pixabam. Okay, so all these drugs are used for the treatment of deep vein thrombosis. They just work on factor, they inhibit factor 10A. So the initial treatment for warfarin is that when we start with 5,000 international units to 10,000, followed by an infusion of 1,000 units per hour. And after we check the INR 6 hour to make sure that the 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 specific INR which we want to get has been achieved. Okay, that's for heparin. Okay, so heparin anticoagulation just prevents the extension of the thrombus. Okay, heparin anticoagulants is related to direct activation of antithrombin 3. Okay, so it's important for us to grasp that concept. The antithrombin 3, the body's primary anticoagulant, it activates thrombin and inhibits the activated factor 10 and factor 9 in the coagulation process. Okay, so that's the mechanism of action for heparin. So we've got unfractionated heparin, which we have already talked about. Okay, heparin must be overlapped for 4 to 5 days with warfarin. Okay, because of the initial transit hypocoagulable state induced by what? By heparin. Okay, so we've got a low molecular weight heparin, which is Clexane or enoxaparin. Okay, which can be used as well. We've got Fandoparinex, which inhibits factor 10A. Okay, so it does not increase the prothrombin time or activated partial prothrombin time. Okay, so we have got warfarin as well, which we use as the mainstay drug after for most patients, which is taken orally after they have been put on heparin. We give them we discharge them on warfarin to go and continue drinking because it's convenient. It's orally rather than giving the patient injectables all the time. So the main mechanism of warfarin is that it inhibits or interferes with hepatic synthesis of vitamin K dependent coagulation factors. Okay. So you need to make sure the patient you check the INR maybe twice a week or weekly for make sure that it's between 2 to 3. Okay, and the dose for this is about 2 to 10 milligrams. Okay, so the treatment duration for patients on warfarin, uh, After you have maintained the dose, the INR of the international normalized ratio to from between 2 to 3, you need to if it's a surgery provoked DVT or pulmonary embolism, treatment should be for at least 3 months. If it's a transit risk factor induced DVT, treatment should be at least 3 months. If we know the cause, okay, it should be at least 3 months. If it's first unprovoked proximal DVT or lower moderate bleeding risk, okay, the treatment can be there can be an extended treatment consideration with the period. It can be greater than 3 months. Okay. If it's a first unprovoked DVT or pulmonary embolism with high bleeding risk, treatment duration is of 3 months. Okay. So initially the normal duration is between 3 to 6 months, okay, for patients on warfarin. Okay. So if we know the cause is 3 months, if it's a if it's some cancers, we can even go to from 6 to 12 months, just like that. Okay. So we need to regularly check up and follow up these patients to monitor their INR, because we do not want it to go above 3 and we do want it to go below 2. Okay. Okay, so surgery for patients with DVT is indicated when the anticoagulant therapy is inactive or it's unsafe or it's contraindicated. Okay, the main surgical procedures for DVT are clot removal and partial interruption of the inferior vena cava to prevent pulmonary embolism. Okay, so we're going to do a thrombectomy. A thrombectomy is just thing. It's just a mechanical method of clot removal. Okay, it may involve using an intraluminal catheter with a balloon or another device. Okay, so we're going to go in there and we're going to break the clot using some spins or an oscillation movement there. Okay, to facilitate the removal of that clot. Okay, so this is how the pulmonary emboli looks like, or the clot. Okay, it's very big. So when you're doing the thrombectomy, you can use a vena cava filter, which can be placed during thrombectomy. This filter traps large emboli, okay, and prevents pulmonary embolism. Okay. So in patients with chronic ilio vein compression, a balloon angioplasty with a stent placement may successfully treat the patients. Okay. So the other thing that we need to be aware of when treating patients with deep vein thrombosis is what we call post-thrombotic syndrome, which occurs in 23 to 60 patients in 2 years following DVT of the leg. Okay, so symptoms of this post-thrombotic treatment may be heaviness, itching, edema, varicose veins, brownish or reddish discoloration, and ulcer or pain. Okay, the treatment for this patient, so those were the symptom, that was the symptomatology, but the treatment for these patients may be proper leg elevation, maybe compression therapy with elastic stockings, maybe wound care for leg ulcers. You can also do an angioplasty and vascular stents in the proximal thrombosed veins by an experienced vascular surgeon. Okay, and it provides significant relief for swelling and healing of ulcers. You can also do compression bandages, which are useful in treating edema. Okay, the other thing we need to do is prevention of initial and recurrent DVT. Okay, and early immobilization. So the earlier you treat the DVT, there's a lower risk of these patients having a post-thrombotic syndrome. Use of compression stockings and electrostimulation devices, and you keep these patients on anticoagulation medication. Okay, so thank you for tuning in this lecture. Stay blessed, and hope you've learned something from this topic.